Thank you all so much for joining today's Public Health Discovery Seminar Series presented by Dr. Patty Kissinger. My name is Cassietta Trewick. I go by Cassie. I'm one of the admission counselors here at the City of Sky Weatherhead School of Public Health and Tropical Medicine at Tulane University. And I have the pleasure of introducing Dr. Patty Kissinger, who is presenting Breaking Down Disparities in HIV/STI to the Check It program. And so I'm going to let Dr. Kissinger take it away. Before Dr. Kissinger take it away, we will be doing a Q&A session at the end. So if you, by chance, think of a question, drop it in the Q&A chat. And all right, Dr. Kissinger.
Great. Thank you so much, Cassie. Appreciate it. And thanks to all who are attending this talk. This is a labor of love. This is Check It program. We're in our second phase of the Check It. We did it for 5 years, and then we are now reinitiating it. And I'm going to talk to you about how we're going to break down particularly sexually transmitted infections among the African-American young population. Anybody who knows who these people are, if you're wondering, this is Kendrick Lamar here, and this is Glorilla. These are sort of our poster children for our program. So the first thing, I just wanted to make a quote from Dr. Martin Luther King: "Of all forms of inequality, injustice in health is the most shocking and the most inhumane." And with that in mind, the grant was started to try to reduce disparities. You're going to see throughout my talk that African-American youth are disproportionately affected by sexually transmitted infections and HIV. So we were mostly interested in this grant in the sexually transmitted infection called chlamydia. It's the most commonly reported sexually transmitted infection in the United States and actually worldwide as well. Most people who are infected do not have symptoms. So this is part of the problem. We have to go out and screen them. So there's not a prompt to come in to get screened. Even though you have no symptoms, it could be causing a lot of problems, which I'm going to talk about in the next slide. You can get chlamydia through any kind of sex: vaginal, anal, or oral. So we used to only think it was vaginally or, vaginal penile sex, but we now know it really any of the sexual organs can be infected. There is no FDA approved vaccine, but testing is really quite simple. For women, a urine swab, or persons with a vagina, it's a urine or a swab, urine for men, swab for women. We use nucleic acid amplification tests, which are highly sensitive. And then if you're found to be positive, we simply treat it with a course of antibiotics, and you should be cleared of the infection. So that would be great. It is a obligate cellular infection. It does tend to go towards the endocolumnar cells, so you'll see a lot of infection at the cervix, but it can cause urethritis and other things. So in women, it causes pretty important female reproductive outcomes, such as right here, you can see this is pelvic inflammatory disease. It's a cartoon, so usually this happens bilaterally, both sides, but just for illustration, this is a normal fallopian tube. This is a highly inflamed and infected fallopian tube. This can burst, and that's an absolute emergent experience. It can also cause what we call ectopic pregnancy. So the sperm can get up into the vagina, the egg can get into the tube, the fallopian tubes, and conception occurs, but that egg can't get through because it's blocked by the scar tissue. So that is another emergent situation. It can also cause endometritis, which is painful and annoying and can lead to, pretty severe outcomes such as PID and ectopic pregnancy. In men, the most common thing that happens is they will get urethritis, which is an infection at the tip of the penis. They can also get epididymitis, which is sort of swollen testicles, and they can get prostatitis, which is the prostate. It can ascend up into the prostate. So it is an important infection, but mostly the men, one of the biggest problems is that the men serve as a reservoir for the women who have some of the more serious outcomes. It can also cause non-sexually important events, such as trachoma, means eye. So one of the first times that they noticed chlamydia was blindness in the eye. Babies, they now do screen pregnant people, and they also crudate the eyes of the baby so that they don't get these infections. It can disseminate, so you can get all sorts of like arthritis and things like that that can cause long-term problems. Chlamydia can also make you at higher risk, and actually any sexually transmitted infection places you at higher risk for HIV because it causes inflammation. Inflammation is never your friend. It recruits CD4 cells, which are the receptors of HIV. So we really want to make sure that we keep people as free from chlamydia and other sexually transmitted infections as possible, because that will help them to reduce their chances for HIV as well. The reason why we're so interested in young people is because they account for, while they account for about a quarter of the population, they account for half of all the STIs. They're disproportionately affected. CDC has recommended that all women under the age of 25 get tested and treated. They do not have recommendations for men. They say it's too hard to find men. They don't know how to get a hold of them. They're not sure that it's going to have any impact. So that was why we set out to do this study. You can see that screening of women alone, which is what we've been doing since the 1990s, it doesn't work. This graph demonstrates how the rates of chlamydia, or the case rates of chlamydia, have continued to increase over the years and don't seem to be quelling. They quelled a little bit for parts of the United States, but Louisiana and New Orleans specifically, very, very high rates. So who's at risk for chlamydia? Well, you can see that if you see every star here, it says Black. So African Americans are at highest risk for all of the STIs, for HIV, for chlamydia, for syphilis, and for gonorrhea. So this is a terrible health disparity that we are setting out to reduce. You can also see that there's a much larger concentration of these 4 STIs in the Deep South. So you can see that chlamydia, wherever you see the darker areas, that's where the rates are highest. So you can see for chlamydia, it's very high in the Delta South. You can see gonorrhea also very high in the Delta South. HIV also high in the Delta South. Syphilis is a little more dispersed, but we still see very high rates in Orleans, in Louisiana, and some of the other southern states. If you look at a population-based study, because a lot of the data that I just showed you are case rates, this is actually true prevalence rates, and you can see without a doubt that African Americans have it at higher rate. I hope I've convinced you that African Americans are a population at risk for this. We also see that while you're seeing the rates of 14 to 19-year-olds is higher than older people, you can see that the 20 to 24 is the highest. So we decided to focus our efforts on the 15 to 26-year-olds so that we can capture the highest population that might be at risk. And I mentioned this already, young people are at a high risk. They account for disproportionate a number of STIs. Why target New Orleans? New Orleans has the highest rate of chlamydia in the country. It's the metropolitan statistical area with the highest rate, and we have been for a long time. Sometimes we're neck and neck with Mississippi, but presently we have the highest rate. And I already talked to you about African Americans. They're almost seven times more likely to have chlamydia than their white counterparts, youthful counterparts. So CDC said, well, we're going to suggest that women get screened. We don't know about men. We don't really know how to get at them. We don't really know if it would make any sense. So this study was to look at feasibility and efficacy of screening men. So we started with men in phase 1. And but we're up against a lot of issues. When you talk about African Americans, there's lots of barriers that are different than for other populations. First of all, you don't have symptoms, so there's no prompt for you to go get tested. There's mistrust of the medical system. There's fear. There's embarrassment, stigma, even magical thinking. I hear kids say, well, if I just don't think about it, won't it just go away? Well, not really. And then, of course, discrimination in general. African Americans, because of structural racism, definitely experience that. So our research question, and we've adapted it now for women as well in phase 2, is community screening of African American youth feasible? Can we even do it? What are the best ways to do it? And will this bundled intervention reduce chlamydia rates in the community? So if we screen in just a small group of people that we believe to be in a high prevalence population, will they reduce the rates in the community? So that's what we're doing. And so a little tricky. It takes a big multidisciplinary team to do a complex intervention like this. So you can see we have me as an epidemiologist. We have an economist who's doing our cost studies. We have a behavioralist who helped us with figuring out how we word questions and things like that. We have a medical doctor, Dr. Tina Simpson. We have a community advisory board that's constantly providing us with information on how we can make it so that it's acceptable and feasible and mostly acceptable to the population. And then a great staff of graduate students. And I think we even had a couple of undergrads in here, but we have a really great staff. This is actually at a recent kind of Halloween party. The intervention itself is a community-based screening, but it has a lot of components. So not only are we going out to barber shops and historically Black colleges and universities, we're also going to wing shops and beauty shops and all sorts of, and recreational facilities. So we're going into the community rather than them having them come into a clinic, which is sometimes very scary for a young person. We also added in peer referral, and I'm going to talk about that in a little bit, but we are incentivizing people to refer their peers into the study. We also give them screening reminders to get rescreened. So anybody who is positive for chlamydia per CDC recommendations should get rescreened 3 months later. We also are giving medicine to that individual for free and for any of their sexual partners they want to treat. This is called expedited partner treatment. It's legal in almost all states of the nation. And so what we do is we give them medicine, they deliver to their sexual partners, they choose who they want to deliver it to. And so that's how we avoid intimate partner violence. We also have a web education where we put on information that may be of interest to our intended population. And we give them a modest monetary incentive for being in the study. We give them $30 for being in the study and $20 if they refer any of their friends and the friends actually enroll in the study. So it's really simple: seek, test, treat. We seek them out at these venues. We test them. For men, it's a urine. For women, it's a swab. And if they're positive, we give them azithromycin, which is the second line. We would like to give doxycycline, but doxycycline can't be given because we don't know the pregnancy status of any of the women. So we give azithromycin, which in this area is still highly effective. And so then we also give it but then you have to think about so all they have to do is give these things and they get it. But you also have to think about the sexual network. So the partners also have to be treated. And sometimes they have more than one sexual partner. So we have to treat them. So we have to consider, this is all sexually transmitted infections are sexual network infections. They're not just one individual, it's their whole sexual network that needs to be treated. So this is a heteronormative figure, but because the study is the start, we enroll people who are engaging in penile vaginal sex, then we want to get at their sexual partners as well. So recruitment and education, we went in Check It 1. We engaged the Youth Empowerment Project to help us with the website, to help us, serve as our community advisory board. That's the website there. If you want to look at it, you're welcome to look at it, checkitnola.com. We started out with Kendrick Lamar, who was our poster child, and then we moved on to women as well. We flyered everywhere because people in Orleans Parish in New Orleans are very verbal. We like to talk to people. So just posting up something on the bus isn't enough. You really have to talk to them. So we distributed flyers and we talked to people. We went into all of our community partners and engaged with them. We also have a very active social media campaign where we do things for engagement and also things for education and also to promote recruitment. So this is an example. We have on our website, we have a Nope or Dope, and one of the things that we posed out was paying women for sex. Is that good or bad? Nope or Dope. And in this young group of young men, this is not women, this is men, they said, yeah, nope, it's not cool to do that, but 29% said yes. Anyway, so referral of partners, we started off by not incentivizing it at all. Then we moved to $5, and finally we moved to $20, and we think that's the sweet spot. And so people they won't do it for $5, but they'll do it for 20. And so it's really a good way to really penetrate into the community much more deeply than us just going to venues. We can really find people that are at high prevalence and really need it. This is our shirts that we use. So all of our staff and our partners are given shirts that they start to recruit for us. And so these are our models. This is our data manager, Akalesh, and this is our program manager, Momi. You can't see her face, but they're both wonderful. And I think Gabriella is one of our field counselors, and I think she's on the call right now too. So how do you evaluate a program that's complex, has multiple pieces, parts, and also, we can't use case rates because for those of you who have taken any epidemiology, case rates are just how many cases were reported to the Office of Public Health over the census. It's not really accurate because depends on if people got tested or not. And we know that just shy of about 50% of our young people ever get tested. So we really need to amp that up and get more people tested. So we decided that we were going to use Medicaid data, because Medicaid, we know if they got tested, if they were positive or negative. So we have both those pieces of information, so it's more accurate. It might not be completely valid, but it's accurate and it's reliable over time. So we use those data. We also used, because this is sort of implementation science, we use the REAIM framework, which is reach, effectiveness, adoption, implementation, and maintenance. So when we adapt something, we use this process. It's an iterative process to figure out how we can enact this. So we did that with the peer referral. We started with no incentive. We went to $5, and then we finally landed on $20. And so we're going to use this for adapting the program. Eventually, we'll want to scale this up so that nationwide it can be done. So it's a multi-method evaluation. We use mathematical modeling. We're not using the mathematical modeling now. We did it in the very beginning to see how we should steer this grant. We also monitor chlamydia rates using the Medicaid data. And then we do a series of process evaluations, such as qualitative research, monitoring reach and uptake. We didn't use the salient health belief model too much, but we are monitoring how many people were getting it. And I think it's about 4 months, we've gotten over 150 individuals enrolled, and we're still going strong. And that's largely because our field staff is just amazing. They go out on weekends, they go out on non-traditional hours, and it's great. We also, our partners are really important. Right now, we're working with our HBCUs, but in Check It One, we also worked a lot with our barbers. And we had worked deals with some of the barbers that instead of giving the participant $30, we would give them a free haircut. So we gave the $30 to the barber so the participant could get a free haircut, engage in the study, get tested. If they're positive, give free medicine. So it seemed like a win-win thing. And then unfortunately, the cost of haircuts went up beyond $30 and we couldn't afford to do that, but we're working on different ways of promoting screening with this small incentive that we actually have. You can see trust is so important. It's really important that people feel comfortable that we're going into their space. And so these are some of the folks that we engaged with in community partners in Check It One, and we're re-engaging with them now. You can see it's a series of barbershops and lots. I love the names of these barbershops. And also colleges and universities, and then other locations. We did a lot at the New Orleans Recreational Department. And then we had a robust media campaign, sort of. And so these were some of the flyers we put out. And these are some of, how we were able to show people African-American young men are really not very included in studies. It's probably, for many of these young people, it was the first time they'd ever engaged in any kind of study. And I would say probably the same thing is true of young African-American women. So we really have to gain their trust. We really have to understand it's the community. We're going into their space. We have to be respectful. And so we did a lot of focus groups, and our community advisory board helped us decide which are the best ones. The population of guys did not like this one so much. And I'm sure you can all say in your head why you think they didn't like this. It's probably because it made it look like she was in charge and he was just following along. They didn't like that one. The ladies might like that, but the men did not. So we did not use that one as much. And even the logo, we started with this logo and we used it for the first 5 years of the study. Then we thought, since we're adding women, we should maybe readapt the logo. Logos are important, the Nike swoosh and all that, very important. So we engaged I'm Building Something, which is an African-American owned media group. And so they gave us a lot of different options and we did focus groups on them. And guess what? We came back with the exact same Basket crown that we had used in Check It One. So we're back there and and we're good. So the way that we also kept our partners engaged is a newsletter. So we sent out a newsletter on a frequent basis, quarterly at least, so that they could see where we were recruiting. And then we had parties for the partners, particularly at the winter break. We had a party and gave some prizes and things like that. Well, there were lots of successes and also quite a few challenges. So I'm going to talk a little bit about those. So the challenge is, how do you increase getting more and more people enrolled in the study? And so that is, we're constantly working with that. I think that the biggest thing is getting the trust of the partners. The partners are a conduit to this population because they know the population, they know what the population wants. And the people themselves in the population are also great ways that we can recruit other people. If anybody knows this show, this is called a show called Insecure. This is about 7 years ago. I guess this main character had chlamydia. And so when he had chlamydia, we got a huge boost in people enrolling in Check It. So the power of media is amazing. It's also very expensive. I couldn't put on a show like that, but they happen to have, so kudos to them for bringing up a topic that's probably not that acceptable, or not people don't want to talk about it that much, but they did that and that really helped. So what are some of our findings? So in the qualitative, we found that people were really worried about privacy. They just didn't want people to know their business. They just didn't want people to know they were getting tested. They certainly didn't want to know their results. There's also some fear of conflict. People are like, well, if I'm positive and I have to tell my partner what's going to happen, you know, but I would say that people are mostly very savvy. So if a person had chlamydia or gonorrhea, at that time we were just doing chlamydia or gonorrhea, they would know this partner might not react properly, so they wouldn't give that person medicine. Lack of knowledge about the infection. We did have people saying, oh my God, I have chlamydia. Do I have to take medicine for the rest of my life? They were conflating HIV with chlamydia. So really, it was important to dispel that. We don't have excellent sex ed in this state. And so really, just any kind of information we could give them was helpful. Fear of stigma. They didn't want people to know about it. Loss of confidentiality. They were worried who would know about their results. And then also, because these are young people and a lot of them didn't have cars, transportation was a big thing. So we adapted our study accordingly. For example, with transportation, we knew that they couldn't come in. We were originally doing it at Walgreens. They could go to any Walgreens. But we found out soon that they didn't want to go to Walgreens because they knew people at Walgreens and they knew the people that were working at Walgreens and they would know who they were. So some kids didn't have transportation to get into Walgreens. So we now deliver the medicine to them if they need it, or we mail it to them. They can come pick it up at our community pharmacy, which is a Central City pharmacy in Central City, but also many of them are opting to have it mailed to them or actually delivered by one of our staff members. So these are the data, and Dr. Charles Stecker, who's our economist, did this. And what he did was, if you looked at the dotted line, that's the control area. So any parish outside of Orleans Parish is the dark line. That's where we did the intervention. We started the intervention about 2016. And you can see by the time we did this evaluation in 2018, that the rate of chlamydia in the community, using Medicaid data in the community of women, went significantly down. Whereas in the other areas, it remained high. So we felt that that was pretty good evidence that our intervention did indeed work. We also mathematically modeled it. We had some brilliant mathematical modelers, Jolene Q and Dr. Mac Hyman. They did this, and they showed that when you start the male intervention, it's going to not only reduce the rate in women, but also it will reduce the rate in men, but it also reduces the rate in women. And so, but you can see that it's not, if you pull the intervention out, it's not like you can't just do it once and then you're out. You have to continuously do it to keep those rates down. I didn't mean to put that in there, but anyway, we did a lot of looking at sexual networks, and we found that if people were in a highly networked environment, that they were much more likely to have chlamydia. And so that is something. The modeling results, we also found that, and I'm not going to go through this because it's pretty complicated, but suffice it to say that the more you screen, the more you're going to reduce the rate. So for every 5 men screened, you prevent 1 case in women. For every 16 men screened, you prevent 1 case in men. So this is kind of the punchline to all of that mathematical modeling. We did the cost effectiveness. And while the cost effectiveness itself may not look so dramatic, it didn't cost anything. It really saved $18,000. So we parsed out what was the study and what was the actual program. And Dr. Stecker, again, who's an economist, we did time, motion, studies, and we found out that really you could save about $18,000 from doing this program per year. So it didn't cost money, it actually saved some money. It didn't save dramatically, but it saved some. We did a lot of other studies. I'm not going to go into them, but suffice to say, because of these studies and that REAIM framework, we found out that HIV was indeed a concern in our population. Syphilis was a concern in our population. And so we also decided that we were going to add on HIV and syphilis screening because that's what the population wanted. Also, in the course of the first check-it, we found out that not only can chlamydia be transmitted genitally, there's a lot of infection that's transmitted through the anus and through the oral cavity, specifically the pharyngeal portion of the oral cavity. So we also added, decided to not add anal because the complexity of that would be so great. And it was not, focus groups told us they were not interested in that, but they were very interested in the oral testing. So we added in oral testing. So in our next phase of the study, we added women. We added the extragenital testing, which is, doing the pharyngeal swabbing in the back. We added HIV and syphilis, which increased the complexity of the study a bit because you now have to get a blood test. So we could do a blood test by using a lancet, and then they just drop the bloods into a little tube. So it makes it a little more complicated, but surprisingly, we are finding that our population is doing it. The first 150 we did, there were very few people that refused to do HIV and syphilis. Some did because they were freaked out about needles, but it's not a needle, it's a lancet. But most people can do it. Diabetics do it all the time. It's not really that complicated. The HIV testing right now we're mostly doing it from just an oral swab you stick in your mouth. It's called OraSure, and it's a point of care test. The syphilis test is also a point of care test. So that also raises concerns about, like, how do you counsel them in the field when you find out they have HIV or syphilis? So we're working through that, and we've got all sorts of protections so that other people can't see the results, and we have a way that we're going to talk to them separately about it. Anybody who's HIV or syphilis positive necessarily needs to go to a clinic. We couldn't possibly treat them in the field. HIV requires ongoing lifetime medication. Syphilis requires an injection and also monitoring. So those folks get immediately referred to our partnering clinic, Ruth Fertel Clinic, which our medical director is, our medical investigator is the medical director at that clinic. So we warmly pass those people on so that they can go through all that in more intensive intervention. Chlamydia and gonorrhea, you can just give them medicine and it's usually fine. As long as you treat their sexual partners, everybody should be good. But still in all, we are calling them back. Anybody who's positive for chlamydia or gonorrhea, we call them back at 3 months to get them retested to make sure that they didn't get reinfected, because this can happen. And then we are also continue, as I said, to refine our peer referral. We've come up with a new idea that we're going to test out as an ambassador program. So there's places like, I'm not going to say their names because we haven't really engaged them yet, but some of our really excellent community partners have access to a lot of young people, and we were going to go in and train them on how, because they don't always know how to talk to other kids. Oftentimes we're on our cell phone, we don't really know how to talk. So we're going to teach them what's the best practices in recruiting people, motivational interviewing, and also give them a t-shirt, and then they can refer up to 20 people, and they get $20 for each person that they refer that's eligible for the study. And so the study, you have to be African-American, you self-identify as African-American, you have to be between the ages of 15 and 26, and you have to live or spend most of your time in Orleans Parish. So if you any of those things, you are eligible for the study. Oh, you also have to have had penile vaginal sex at some point in your life. So we didn't, there are plenty of programs for exclusively gay individuals. There are not that many programs for heterosexual. We do have about 7% of the population was bisexual, and it might be more this time. But we wanted to make sure that they at least had vaginal sex at one point, because you can't transmit it generally unless you have vaginal sex. We've also offered to increase access. We added in a televisit. So people can sign up online. We call them up, we mail them a kit. and then we schedule an appointment. We show them all online how to do it. We have videos, and we have somebody that can enroll them, and that's working quite well. Not everybody's opting for that. I think people would prefer to do it face to face, but for those who have very restrictive schedules or can't simply make it into one of our partnering sites, this televisit is a good option, and it really has helped. So our ultimate goal, as I mentioned before, is to refine this, to package it, and then hopefully scale it up so that we can do it in a nationwide manner. There are some issues with the home testing that I just want to bring up. So we have to mail these kits, and we have to keep them. They can't be in like 103-degree heat. And so in the middle of summer in New Orleans, that's what we got. So we're still working with how we can make sure that the temperature is maintained. We might have to put coolers in there. We're now in a period where it's not as hot as it was in the summer. So we're going to have to deal with that next summer. But we also have to deal with porch pirates. There's people that steal packages not knowing what's in there. It would be of no value to them, but they wouldn't know that. So they steal a thing. So also people sometimes, we can't read the address, or they give us the wrong address or something. So sometimes we have issues with wrong addresses. And then sometimes we were worried, you have to be able to read. So this is clear that that's positive. This is clear that that's negative. This is indeterminate. And so we would probably either rescreen them, or we would just go ahead and treat them because that is presumptively positive. So, but we have to train them how to do that. Also, sometimes, the whole thing of putting a lancet to your finger, people need to know how to do that. What are the techniques? You have to, massage your finger. You have to keep your fingers warm. You have to, do a lot of that. So there's a lot of sort of pieces, parts that require us to make sure that that it is acceptable and feasible, and that people are getting, following through. I think so far out of 150, we've gotten about 7 chlamydia positives, one syphilis positive, but it turns out that person already was known to have had syphilis. So our test would not be accurate because it's only for people that have never had syphilis before. So that person we referred to the clinic for more intensive follow-up. We have not had any HIV to date. I'm sure we will get some at some point, but we have not gotten any, thank goodness. And like I mentioned, we just have a really great staff, many students. Haley Thompson, Gabrielle Cotton, our outreach coordinators. Akalash Kandagula is our data manager. Momi Sajao is our program manager. And we also just have community. We don't have one community advisory board because kids move around a lot. So we assemble it when we have a question. So we find kids that represent our population, and we ask them questions about how can we adapt this so it'll be of use to you. I didn't mention also, we do a survey, and the surveys, we get a lot of information on sexual partners, sexual networks, how many partners they have, the nature of the partners. Also, and we've been able to find other predictors that people didn't really discuss so much. We did find out if our clientele had been justice involved, they were they're 3 times more likely to have infection. So, so going to areas where kids who are justice involved would be also of great benefit. So we're learning as we're going along, and you'll find in public health, it's always about learning. We're lifelong learners. We continuously, once you answer one question, you oftentimes just open up to 10 more questions. So that's why research is so fun, and that's why public health is so fun, is because you're never just stagnant doing the same thing over and over again. You're always kind of trying to refine and reevaluate and adapt. Unfortunately, this grant was taken away at one point. We were able to fight it and get it back, but this is a very trying time for public health, but we are continuing on, and we're continuing to submit grants, and we're continuing to do the best we can. I think I spelled Hayden's name wrong. Anyway, so I just want to say thank you so much for your attention. I guess I went a little faster than I thought, but I'm sure you'll have questions. And if anybody wants, if you live in Orleans Parish and you're in that group, 16 to 26, African-American, live and work in Orleans Parish, and you want to sign up for the study, here's your QR code. However, if you're not in that, but you know people that are in that population and you want to peer refer for us, sign up and we'll get you a number and you can be a peer referrer for us. So great.
Thank
I
you so much, Dr. Kissinger, for that lovely seminar today. We do have two questions in the chat already. The first one, it's amazing that you're able to deliver medication to the participants if they tested positive. How are you able to constantly fund this project in today's climate where inflation is on the rise?
Great question. We were able to get a letter of commitment. See, these medications, azithromycin and cefixime, are not very expensive. They're probably going to go up a little bit, but I'm hoping it won't go up. It won't break the bank. Azithromycin's been around forever. Cefixime has been around forever. Those are both oral medications, so they don't have to go into a clinic. If they went to a clinic, they wouldn't see a doctor. It would probably be a nurse that would either just call in the script or give them the meds. So you don't have to have a physician for chlamydia and gonorrhea. You definitely need a physician or a healthcare provider for HIV and syphilis. These are much more complicated STIs. I hope that answered your question.
Next question says, I'm considering a DRPH application in IJSD. Do you accept DRPH candidates for mentorship and coaching purposes?
Do I do what? Do I? Personally?
Do you
Oh,
accept
yeah, I have lots of
DRPH?
doctoral students. I can't take on any more doctoral students specifically, but I mentor and I talk to and I hire lots of people to help. I don't care what department you're in, because I care more about the skill set. So that's the most important thing. But of course, I think any of our faculty would be happy to informally mentor any DRPH or PhD or graduate student or undergrad. I mentor a lot of undergrads too. So we're happy. Well, our job, we want to form more public health practitioners. This is one of our goals at the school, is to build up the workforce and make sure the workforce is well trained and as ready to engage in this. So yes, I would be happy to talk to you at any time.
With so much stigma in the African American community regarding STI testing, what were some of the best practices that you used to address this?
Well, I think that it's the most important thing is getting out of the clinic. Clinics are scary for people, especially young people that don't go to clinics. And a lot of the young people have to use their parents' insurance and they don't want their parents to know about it. In Louisiana and many states of the nation, young people as low as 15, not so much 14, but 15 can go in for STI care without consent of their parents. So that's another thing, getting rid of that stigma that people are worried that their parents are going to be upset. Also, we try our best to make sure, I mean, we do assure confidentiality. And so we were responsive when we heard that people didn't want to go to Walgreens because they were afraid that they would see somebody there. We heard that and we adapted accordingly. And so now we mail it. Now that is also tricky because you can mail and maybe the parent or a girlfriend or boyfriend can intercept the package. So we make sure we offer, I think it's mostly about offering options. No group is a monolith. Everybody has different things that they need, different needs, different desires. So we try to adapt our program so it's as flexible as possible to meet the needs of these young people that are, many of them are busy. They either have jobs or they're school, they, have an active social life. So it's really hard. And also young people, you can't have like a 9 to 5 clinic because they don't always get up that early, and also a lot of the clinics don't look that friendly for younger people. So getting out of the clinic, I think, was one of our first things to be as responsive as possible to this population.
Thank you. Please feel free to drop more questions in the Q&A chat.
And if you have any suggestions for us, I'm super happy to listen because you're all these bright minds on this call, I'm sure have thoughts and ideas about this. We're super proud of this program. It's really been a labor of love. I'm so happy that my staff is just really engaged and really I'm always listening to my staff because they always have good ideas. And so that it's really important. And most of them are Black themselves. So that is, people want to see people that look like them. That also helps break down a barrier. And so that is, and it's not to say that you have to be Black to be in the study. You definitely to be a staff member on the study, but in some ways it does help. But it really is how you engage with the individual. So if you are understanding and caring, that's the most important thing, really.
Next, so we got some more questions, Dr. Kissinger.
Sure.
When it comes to the counseling sessions you mentioned, how is your team trying to be able to provide those sessions? Are they trained explicitly in counseling, or is it more based in science?
So it's based in science and counseling. So what our staff members went through a very extensive HIV training. You get certified in HIV counseling and testing. So 2 of our staff members went through that training, got certified in counseling and testing, and they're training of trainers. So they went ahead and trained our other individuals. If it's a person who has HIV or syphilis, we tend to send them to the certified ones, because until we get that really, chlamydia is not, it's important, and we have to make sure that they understand it's treatable and it's not, and it really exists, because some people are like, that's not a thing. I don't have chlamydia. I don't have any symptoms. So trying to explain to them, well, you don't have symptoms, but it's still there and it can cause problems, and it's going to cause problems for you later on. So the counseling is based in social science, and we use the social science methods. We use a thing called motivational interviewing to try to get people on the study. There are people like, I'm good, I don't need that. So we say, oh, you don't need that? Tell me more about that. So you use the ORS process in motivational interviewing to try to convince. Of course, there's always autonomy. People always have to be able to say no, but we want to make sure that they're making an informed decision about it.
This person stated, I don't know if you said this already, but is there any internships available?
There likely are. If you are a Tulane, well, you don't really even have to be a Tulane student, but there are internships available if you send me your CV. My email is kissing, KISSING, kissing at tulane.edu. So I was one of the first people at the school to get an email. And so they thought that was funny because I work in STDs. So they gave me kissing at tulane.edu. So if you send me your CV or your resume, we can see about it for sure. Constantly take. Right now we have about 8 or 9 graduate students, and we did have some undergrads, but now that she's moved into a graduate school. So most of them are graduate students, 2 doctoral students. And there's always, there's turnover because people graduate. So just let me know.
And I definitely dropped Dr. Kissinger's email in the chat, everyone. So please feel free to utilize her email. The next question we have, can you provide information on the HIV counseling and training your staff received?
Sure. So they went to a place called Crescent Care. So Crescent Care has a training for HIV counseling and testing that is sanctioned by the Centers for Disease Control and Prevention. It's very methodical. They go through the didactics of it. They go through the testing. They go through giving results. Then they do it with shadowing another person. Then they have to do it themselves. And the shadower then evaluates them and gives them a grade. And if they pass, they get the certificate. So most offices of public health have such a program. I bet if you Google it online, wherever you are, you can get that. It's not offered like continuously. So like I think it's here offered at Crescent Care twice a year, maybe 3 times a year, and you have to sign up for it. So yeah, that's a great thing to have on your resume, or your resume, to show that you've got that counseling and testing ability.
And also, guys, I did drop Crescent Care website in the chat. So if you're interested in wanting to do get that certification, please click on that website. The next question, any resistant information on azithromycin to chlamydia?
There are, yes. So the CDC and other agencies they prefer doxycycline, and doxycycline for 7 days, twice daily for 7 days, because they did see some resistance for chlamydia in the West Coast. We do not have that here in the Deep South yet. We'll probably get it at some point, but we don't. To be able to do this, we can't use doxycycline because doxycycline can cause some dental aberrations. It causes staining of teeth and things like that. So we opted for the second choice, and I ran it by medical boards, and everybody said, no problem, you're good, do this. So we did it. Gonorrhea, there's lots of resistance in gonorrhea, but the gonorrhea we have here still is acceptable to suffixing. People who have gonorrhea tend to have symptoms more. I mentioned that chlamydia, they don't have symptoms. Gonorrhea, they almost always have symptoms. So if a person had a treatment failure, they would be very likely to come back. And at that point, we would just refer them to our Ruth Fertel clinic, and they would get suffixine, which is an injection. Not suffixine, ceftriaxone, and it would be an injection. So, but we can't do injections in the field. So we're giving them the oral. If they opt, we tell them you could have the option to go in and get a shot if you'd prefer. They almost always opt for the meds. But, we are very open and clear about it. These are the second line medications. If you want to get the first line, you need to go to the Ruth Fertel, and most of them just take what we have.
Next question. Great project with a lot of implementation science. It seems like the intervention is constantly being adapted and contextualized to maximize reach. How are you able to keep up with the adaptations, and how do you think this will play out when the project is scaled up to more diverse settings and contexts?
Yeah. So we are definitely logging it, and we're publishing it, and we're publishing our protocol very soon so that people can see it. The adaptations are not so much the core bones of the study is the same. It's a seek, test, and treat program. Core bones are the same. How we go about it, like, is it $5 or $20 for peer referral? Is it $30 or $50? I mean, we're never going to get to $50, but if is it 20, we started with $20 for the incentive, and now we're up to 30 for the individual to enroll in the study. That doesn't change the bones of the studies. Seek, test, treat, provide, treat for the partners as well. So I think that we just adapt it, and we want to manualize it. And once we manualize it, we can provide that to offices of public health who might be interested, particularly in high prevalence areas. And they could, I don't think this would work in like someplace that has a very low prevalence of chlamydia. It has to be in high prevalence areas, which are usually very urban areas. And the urban areas just tend, because there's more crowding or whatever, more people, you tend to have higher prevalences there.
The next question, are you offering doxy-PEP as possible prevention for chlamydia infections among the participants?
We are not doing that now. We have another study that we're just submitting to do doxy-PEP in women. We now know doxy-PEP in gay and bisexual men and trans women works great. What we don't know is, does it work in women? So we are not, if anybody is interested in doxy-PEP, we refer them to the clinic, and they will do, because doxy-PEP, if you're on it, you have to be monitored. You have to, we couldn't just do this in a community setting. Really kind of one of the spirit of this is to get people who had never been tested before tested, and if they're infected, treated, and then show them where they can go in the future. So they can only enroll in the study once. So it's not something that they can use on a regular basis. It's to stimulate interest, stimulate knowledge, go into their spaces, and then say, look, these are the clinics we have available to you. So we also have a list of clinics throughout the city that provide low or no cost care and screening and treatment. And so that's another part of our mission.
Do we have any more questions?
Well, thank you so much for your attention. All these really great questions. I really appreciate them. And I appreciate Cassie, you all inviting me, and thanks.
Thank you so much, Dr. Kissinger. So if we don't have any more questions, I'm going to give you back 8 minutes of your time. Again, thank you all so much for joining today's seminar series. Thank you so much, Dr. Kissinger, for presenting. And you all have a wonderful Tuesday afternoon. Take care.
Thank you. Bye.